This situation is escalating, and you've tried a number of non-pharmacological interventions to help the patient settle. On your way to the ward, it would be appropriate to call the med-reg to inform them of what is going on, that there has been an escalation in the situation, and you may need their help as you are an intern and feeling overwhelmed with what to do next. Managing a delirious patient isn't a straightforward task, as every patient will have varying causes for delirium. It's important as a junior doctor to realise that in a hospital you aren't alone. When you are working ward call, you may not have a home team or familiar patients, but you should imagine all the registrars on the same shift to be your registrar, and any clinical situation that is new, unfamiliar, or out of your scope can and should be escalated early. It is okay to start a conversation with, "I am an intern, I am not sure what to do," followed by an explanation of what you have done so far and why. Evening ward call first-line management of delirious patient can include orientation, sleep hygiene, using visual and hearing aids, fluid balance chart, both input and output, examination and investigations to look for pathology, bowel chart and consider aperients, pain assessment and consider analgesia, hypoxia management, reposition the patient, and oxygen delivery. Before calling any registrar, unless it is a medical emergency, always do your best to get a history and examination, read the chart, and look up relevant investigations. As a junior doctor, it is not your role to be considering the need for chemical or mechanical restraint, and realistically, this is rarely done and is not recommended practice for delirium. ETG provides some guidelines for chemical options for your education, but leave the decision-making to the registrar. The safety of yourself is the most important. If you believe that the patient could cause you harm, the patients around them harm, or other health staff, then don't hesitate to call a code black. Finally, post-discharge care is important in patients that have experienced delirium as an inpatient. Individualized care plans can be provided to patients and families on discharge to communicate information and strategies to reduce the risk of delirium. A discharge summary outlining the delirium, medication changes, and cessations with justifications should be provided to primary healthcare physicians within 48 hours of discharge, and the patients should have follow-up with their primary healthcare physician within 10 days of discharge.